So I'd like to thank everyone for taking the time today to learn about this important topic and to share this information with you. Today we're going to discuss how combinations of laboratory tests can be combined to help prescribers reduce antibiotic use and then thereby reduce Clostridium difficile infections and then also improve clinical care. So as a side, Christian, thank you very much for the opportunity to share this information. And then I needed to clean my office for a while. So obviously my background's clean, so I finally got there. I do appreciate that. So objectives for everyone. I would like you to be able to comprehend the benefits of the neuromolecular testing. So the beauties of these is a lot of these are direct from testing, and they have a very short time window in which you get a result. And that obviously is a huge opportunity for us compared to traditional methods. Then we'll compare and contrast how some of the most recent biomarkers, such as procalcitonin, can help us do better utilization of antibiotics. They can actually help us differentiate a viral infection from other things. They can help with initial severity assessment and then treatment options. And then finally, we're going to put it all together. So we have this testing piece of it. We'll have the piece where we're actually looking at the procalcitonin and how they can help us better utilize and have better outcomes. The screen that you see in front of you, this came from a 2014 CDC number, and it would suggest that in acute care or hospital setting that up to 50% of the antibiotics we use are considered inappropriate. And what's interesting about this is that while this is a 2014 citation, this number goes back more than 20 years. And I bring this all up to just simply make the statement that we've known this is a problem, but yet for 20 years, we've never been able to improve upon it. And so then it kind of behooves us to think, okay, why is this? Why does this happen? And so there's a number of reasons. One of the common factors is now we have all this focus on sepsis. And so we don't want to miss patients with sepsis. That's very important. But the reality is, because sepsis is a syndrome and not just a test, is that for every 10 patients we put on antibiotics, only 4 need them. The other 6 and 10 don't. So there's that piece where you're getting a lot of antibiotics that are not required. The other is, I think we just don't fully appreciate the consequences of what we do. I think a lot of prescribers would tend to think in terms of, I'll do what I want to do. The guy next to me, the lady next to me, everybody else can do a better job somewhere else. And that's really not what we need to do. And then thirdly, there's this just very important concept. It's like antibiotics are what I would consider the clinician's anxiolytic of choice. And so they will give an antibiotic when in doubt, just to be sure. And this is a very common occurrence. I'll talk to providers. I'll say, well, why are they on this particular broad spectrum antibiotic? And it's like, well, I wasn't really sure, but I wanted to make sure then that I did cover them just in case. And then you'll ask things like, well, is it time to stop antibiotics, which we obviously know a lot more about than we did years ago. And they'll say, well, how about a couple more days just to be sure? And so essentially what they're doing is treating themselves rather than actually doing what's in the best interest of the patient. And so on the surface, it seems like it shouldn't be that hard to use antibiotics, right? I mean, essentially, it's like it shouldn't be that big a deal, but really it is. And there's really two key things. One is it has to do with the signs and symptoms of these things, these clinical presentations overlap. And the other had to do with the laboratory testing that we had, that lack of specificity for bacteria, which is a key. So if you think in terms of the most common respiratory tract infections we have, COPD, which is chronic obstruction of pulmonary disease, these smokers that have this issue of breathing. Think about pneumonia and heart failure. Clinically, these patients present very similar. If we think in terms of body temp, there's nothing about these things that scream this is bacterial versus viral or something else. As far as temperature, there are 1,180 things that can drive the temperature of the body up or down. Heart rate, respiratory rate, those things are not specific. They're just simply the consequences of some type of infection. And then we think of what we call the WBC or leukocyte count, and it obviously is not inadequate. It basically doesn't have the ability to differentiate the type of infection. Chest films, they can vary. And then on top of that, a lot of these conditions, you can actually have what we call a co-infection. So you can have basically heart failure co-infected with bacteria or co-infected with a virus, and those make things very complicated. So where procalcitonin comes in, which is one of the tests that I'm going to focus on today, which is also known as PCT, is this elevation in PCT or procalcitonin can help us differentiate the type of infection. It can actually tell us, is it viral or is it bacterial, fungal, or something like that? And so there's the key. To make things worse, when we talk about this sepsis prescribing, the clinician then sometimes they'll go, well, they're really sick. And so they'll say, I want to prescribe differently. And so they'll give an antibiotic that has a broader spectrum of activity or use multiple agents. In doing so, these all have greater consequences. They affect the microbiome, they affect a lot of things within the body. And sometimes they dose differently. Their thought process is, well, a little is good, more is better. And that may or may not be the case. A lot of these drugs are what we call time dependent. It's just that you have to stay above a certain concentration, a predetermined length of time, usually 80% above the minimum inhibitory concentration of the bacteria. And they do just as well. So you don't always have to have these higher doses. And then they'll say, well, they were really sick, I'm going to treat them longer. The bottom line, all this gives greater antibiotic exposure, which is bad in terms of the collateral damage such as C. diff. And they mean well. The thing is that these are good intended people. We prescribe, we think we mean well, but that doesn't necessarily mean it's what's in the patient's best interest. And so one of the things we also run into is that of what we call an inappropriate prophylaxis. So they don't really think they have a bacterial infection. Listen, we don't think they have they have a viral infection, but I don't think it's really bacterial. So let's give antibiotics to make sure they don't become a bacterial infection. And that's obviously against all the stewardship principles. And then unrealistic concern for resistant organisms. You have to remember that we're clinicians, we're driven by a lot of things. And so if you think in terms of what clinicians do is, 99 attaboys, things went really well. Those don't ever register. It's like, those are good. But the one kind of oh poo, when things don't go like they should have, or where you have a resistant organism, that dwells in the back of their mind once they have that. And then the tendency is to prescribe for that 1 in 10,000 or that 1 in something that we really shouldn't do. And of course, this malpractice thing always rears its ugly head. That's an excuse for anything. It's always the excuse to use more, just to be sure, just so that they don't, some of their peers wouldn't say something about it. And the knowledge piece is like, this is kind of interesting. You're looking at people who have to have a very broad wealth of knowledge. It's kind of interesting. I've been at my hospital now. Stewardship is my focus. I've been doing this for 28 years. And when I first got there, I did a survey of clinicians and I asked what they would like education on. And the things that I thought they were the strongest, they were actually, in my mind, the weakest. And one of those was antibiotic use. So as far as the stewardship piece and antibiotic use, that was their number one. They thought they were the best at, and I rated them the poorest at. So sometimes there's that gap of knowledge and just taking the time and needing to learn. So what are the consequences? We use all these antibiotics. What are the consequences? Well, obviously, there's damage to the normal flora, particularly in the gut, which causes overgrowth of many pathogenic organisms, but in particular, Clostridium difficile infection. And the problem is that this microbiome, your gut, is also tied to a lot of things within the immune system. There's actually one very good study done last year where they actually had a study, and was done very well, in the nursing home, people who had received 4 courses of therapy for antibiotics, regardless of duration, that they actually had a higher incidence of mortality or death over that time frame. And so you would think, well, why would that be? And so we kind of coming back around to think what was, think of what caused this. What was interesting is these were cardiovascular deaths. Well, you'd think that has nothing to do with bacteria, but it does, because it causes a whole host of changes and things that take place. And indeed, it's probably this change in microbiome that makes them more susceptible to these downstream cardiovascular events. And of course, these things are not without consequences. Many of these antibiotics have what we call QT interval prolongation. Basically, it can change the heart rhythm and those types of things. And very significantly is that concern of antimicrobial resistance. So in particular, if we think in terms of Clostridium difficile, one of our primary topics today, and its burden in the US, this is a big deal. So hospitalizations from C. diff have doubled. So in the years 2000 to 2010, this is people who were admitted into the hospital. They increased by more than double, okay? This now affects more than 450,000 patients. So the statistics for last year, from 2019, was 453,000 patients were affected. In the year 2011, that was associated with slightly over 15,000 deaths. In 2019, that estimate is now to be 29,300 deaths. That is a lot of people who are affected, and it's a huge cause for concern. Also very interestingly is that once you develop C. diff, because it never goes away, these spores remain in the body. the average reoccurrence rate is 20%, and that's 1 in 5 patients, and that is a big deal if you think about it. A meta-analysis showed that the average Clostridium difficile infected attributable cost per case, this is in addition to cost above that original treatment, was $2,000 or $20,000 from community-acquired pneumonia and just over $34,000 for hospital-acquired C. difficile, and I said community-acquired pneumonia and C. difficile. So when they did this meta-analysis, they also shared that the increase in length of stay was 5.7 days for community-acquired and 7 for hospital-acquired. So these are huge costs and huge lengths of stay tacked on to what was already length of stay that they were going to be in the hospital. That puts the cost of healthcare in almost $4.8 billion. So it's a huge cost alone to the U.S. So our mentality for years has kind of been, remember there was a commercial and they said, there was a Doritos commercial and they said, go ahead, we'll make more. And this is almost what people tend to think about antibiotics, and that's simply not happening. There's just not that financial motivation for people to make antibiotics, because you're talking very short term versus people who want to put on long-term therapy when they can make a lot of money. And then when we do get new antibiotics, we reserve those for just in case type things. And then the cost is thousands of dollars for the treatment. And so these are some of the ones that have reared their ugly head. This is what we call the CRE, carbapenem rosacea enterobacteriaceae. Interesting. So I just had a patient who was tested for this today, had a micro result, and I got a call from the physician, and they wanted to know about a particular drug and wanted to know about dosing. My suggestion to them is that they not even be placed on this, because this was a urinary tract infection, and the procalcitonin actually indicated that that patient was colonized versus actually a patient who needed to be treated. And I'll talk a little bit more about that. Other concerns are the Pseudomonas aeruginosa. You particularly see this in lung infections and some of those with those chronic lung conditions. Acinetobacter, a lot of this is healthcare associated, and Enterococcus. And you can see just over and over again, these are multi-drug resistant organisms that we've always been able to treat, but that we can't really seem to treat very well now. And that actually brings us to this incredibly important point. So it is estimated by the year 2050, only 30 years from now, if we don't change the way we prescribe now, then this is going to be the issue. It will become the leading cause of death worldwide. That will be 10 million patients in just 30 years. So instead of cancer being the leading cause of death at 8.2 million, 10 million people will die from multi-drug resistant infections annually. And that's huge. So literally you could get a scrape on your arm, a cut on your elbow. You could go in for minor surgery and ended up dying because of this type of thing. So it behooves us then to actually do a much better job about taking care of our patients. So what can be done? Let's think in terms of this. So what are the options? We know the problems. What can we do out there? We know that Clostridium difficile infections are in direct proportion to the amount of antibiotics used, i.e. more antibiotics used, opportunity for Clostridium difficile infections. So there's that usage piece. Fewer antibiotics equals fewer C. difficile infections. Now, part of this also in Clostridium difficile, there's that small component of infection control, because these are spores. These can be passed to other people. So that's the second part of it. But basically, in a very simplistic way, reduction in antibiotic use will equal a reduction in C. difficile infections. And a lot of the ways we do that is through the use of antimicrobial stewardship programs, okay? We are now required to have these in hospitals as a condition for participation. It's a joint commission type thing, where we actually do a better job about managing the use of these antimicrobials. And so if we think in terms of what is stewardship, okay, stewardship is very simply, it's the appropriate use of antimicrobials. Does this patient need antibiotics? Does this patient have a viral infection? Do they have a fungal infection? What type of infection do they require antibiotics at the right dose for the right duration and that type of thing? But much of what this we're looking at from these stewardship programs is reliant on laboratory testing. And so really in the laboratory testing, in a very simplistic way, there's two areas. There is that area where we're looking at, is this a bacteria, is this a virus, is it a fungus, a parasitic infection, and then more evidence about what that is, as far as, what drugs will actually kill the organism and those types of things. So this provides us an opportunity to optimize and narrow and define therapy. It will tell us if an antibiotic will or won't work. We can use this for stewardship mechanisms as far as resistance trending and that type of thing, regardless of the method that we get it. And the other one that works hand in hand about that piece is that biomarker side, and this is where procalcitonin comes in. It's that piece of, is this a viral infection? Is it a bacterial infection? How severe is the bacterial burden? And look at your therapy choices and make changes over time. So we kind of have two key components there that come out of lab. So we had that diagnostic piece. Is this a bacterial infection? Is it viral? And do we need antibiotics? Just because you grow something doesn't necessarily mean you need to treat it. And that's where that perceived severity of bacterial infection or burden and load comes into place. Antibiotic selection is based on evidence-based medicine, but that all comes from the information that we get from lab, depends on the location of the organism, those types of things. And then once we begin antibiotic therapy on people, then do we continue that? Do we have resistance? And then how long is it that we treat these people? So all these things come together, but all of these pieces actually come from the laboratory as far as the organism, the sensitivity, the biomarker side, and those type of things. This all then helps us achieve what we call appropriate use, because if not, everything is empiric selection. We start somebody for an antibiotic for X amount of days. We only change it if they get bad. Well, that's maybe, will work in some cases, but it's not the optimal way to use antibiotics, and that's what we'd like to avoid. So if we look at the current methods we have in the lab, we actually have biomarker, we have the traditional microbiologic culture, and molecular. So the biomarker is the piece that we're talking about with the procalcitonin. That's where your white count comes in. There's interleukin-1, interleukin-6, tumor necrosis factor, all of these things. They just tell us something about amounts of chemicals that are within the body that provide us with useful information. And the second piece that of what we call the culture, that's with the traditional way. We collect a sample, it grows on the plate, we take that plate out of a petri dish, and we determine what that organism is and some type of sensitivity. Now, this is useful a lot of the time, but really only 6 in 10 pathogens that are out there as far as the bacterial standpoint actually will grow this way. Many organisms cannot be grown this way, so you can't always result all organisms, and it takes a long time. This takes 16 to 24 hours just to grow it. Then you have to put it in a device to get the actual organism itself. So the time frame may be days before you actually know what that organism is. Some of this newer technology that we talked about, which I would say molecular, some of the terms are PCR, there's mass spec, there's all kinds of things. But what they do is they actually are looking at the genetic makeup of these viruses and organisms to tell us what they are. So they actually can very quickly tell us what the organism is. They can't generally tell us if it's susceptible to something, but sometimes by the genetic makeup, they can tell us resistance mechanism. This is a MEK-A or MEK-B gene adaptation, or there are things like that. So the nice thing about the molecular technology is most of these are directs from specimen. So we can actually have that result very quickly, a lot of times in 1 hour versus days. That's a huge opportunity for us. Here's the problem that we've always had. We studied 175 biomarkers to date, and the problem has always been this. We've always said the white count's the gold standard. But if you look at specificity to bacterial infection, you can actually see it's very, very low. It's only 1 out of 4, and there's 596 interactions with drugs or diseases that can affect a white count. And then we look at temperature, there are 1,180 things. The one thing, the key about this procalcitonin that we talk a little bit about has to do with the specificity, and this is very specific to bacteria. And the nice thing about this, I won't get into the details, it's just very simply is all tissues in the body have what we call the toll-like receptor. And what makes procalcitonin different is that it requires this toll-like receptor to be activated for you to make bacteria, for the bacteria to actually elicit a response. So you can't get a false positive like you do on many tests, like with white count, because bacteria actually has to be present. Once that's activated, then you make procalcitonin and it's released into the bloodstream. So the beauty of this is bacteria has to be present. It tells you something about the initial severity of bacterial burden, how much bacteria is in the body. As you check that change over time, it allows you to assess the effectiveness of your therapy and opportunities to stop earlier. Very, very important key concepts. Then based on the kinetics, the time for it to rise and fall, you can see here that its elimination half-life is 24 hours. Now, simply based on this time, this elimination half-life, this kinetic piece of it, this one test can tell you all this. And this is a very simple concept. So if I have a baseline procalcitonin I get on day 0, that's on admission, 24 hours passes and I get a second PCT, 0.05 being normal. The fact that I have 2 negative PCTs will tell me that I can stop antibiotics. So those 6 in 10 patients that got antibiotics who met sepsis criteria can actually have antibiotics stopped. That's a huge opportunity. And then if a patient is prescribed antibiotics and we see that 50% reduction in PCT like you're seeing here, you simply know that your antibiotics are working. You can continue doing what you're doing. And then if I see increases in the next 24 hours, this tells us that my antibiotics are not working and can change. You don't have to wait till that patient deteriorates clinically. And what this means literally with 2 procalcitonin values in a 24-hour window, I can determine if I need to stop antibiotics, if my antibiotics are working or not, and evaluate my antibiotic therapy, which is a huge opportunity. We've never had that before. So actually in the package insert, there's 2 very notable things. You can see that this is actually approved by the FDA. This is in the package insert, just as I said, to aid in decision-making on antibiotic discontinuation for patients with suspected or confirmed sepsis, and then to aid in decision-making, okay, as far as when to start and stop and those type of things for therapy in inpatients or patients in the emergency department with suspected or confirmed lower respiratory tract infections. This would be our pneumonias, our community-acquired pneumonias, and what we call our COPD exacerbations, which is chronic obstructive pulmonary disease. Now, they even gave us an algorithm. This came through at the same time. This algorithm will actually tell us or suggest to us when we can start and stop antibiotic therapy. So what you can actually see is then based on the PCT value, you can see if therapy is encouraged or discouraged. You can see in values basically above 0.26 that therapy is encouraged. And then notice then that you can repeat that PCT in 24 hours. That's a very important concept. And as far as evaluating that it didn't go up and your antibiotics are working. What you'll also note is that they'll actually suggest when you can stop antibiotics in lower respiratory tract infections with an absolute value of 0.25 or less, or an 80% drop of your maximal value. Very, very important. And in sepsis, remember we talked about that sepsis criteria, 6 in 10 that get antibiotics that don't need it. You can stop if it's an absolute value of 0.5 or less with an 80% drop. Notice the wording. This is from the FDA. It says, cessation strongly encouraged with clinical improvement. This is actually in the package insert. So then let me describe how these things work together. We have this part about getting the organism and knowing a little bit more about it. And then we have the biomarker side, the PCT side, which has that 94% specificity for bacteria. And these are some of the questions that can be answered. So you have a pathogen that's identified. I have a staph, okay, or strep. How many organs are there? In other words, what is the bacterial burden? This values can go from 0.05 as normal up to 1,000. And so this tells me then upon presentation, how many organisms were in the body in a relative term. So is there a lot? Because there's a huge difference between having a value of say 2 versus a value of 20 or 200. This tells me a lot of information about the amount of bacteria that I see. If this organism identified, I grew a bacteria, then the question becomes, is it colonization or infection? So this is one of the huge problems we have in medicine. Let's use the urinary tract for an example. If you get patients who have what, quote, is a suspected urinary tract infection, you do a UA, a urinalysis. And so there's several things we look for in that urinalysis. You're looking for white cells, you're looking for red cells, you're looking for bacteria, leukocyte esterase, and an amount of bacteria, among other things. And so one of the problems is that as we age, about 40% of the aged population is colonized. And what that means is this, is that patients who are colonized will always grow organisms and they'll always have an EUA that looks positive, all right, particularly in the nursing home. And so what this means is this bacteria grows together, it forms a biofilm. Basically, it's like this sticky matrix that goes along the lining of the bladder, the urethra, or whatever. And once it's there, they basically agree to work and live at a lower energy state. So you have tons of bacteria there in this biofilm. And it's very hard once that biofilm is established to ever get rid of it. And so then when opportunities exist where that organism can then become pathogenic, it will then break out of this biofilm and grow and be pathogenic. So one of the things is that with procalcitonin is in these 40% of patients who actually are colonized, if you have 2 negative procalcitonin values, it can actually determine whether you need antibiotics or not. And if I had 2 negative procalcitonin values, I would say do not treat this patient. But if I have a positive or a change to a positive, it would indicate then to treat that. And so essentially all these thousands and thousands of prescriptions that are taking place because you had a urinary UA that looked positive, it may just be a reflection of colonization. You actually have the same process that takes place in the lung, particularly in COPD exacerbations and smokers. They tend to be colonized. So once you grow something out of the lung, you get a sputum or you get a bronchial wash or something, you actually can grow an organism, but if that PCT is normal, at least normal times 2, you don't have to treat those patients. And that's a huge opportunity. Additional questions is, so you have a bacteria, what is it? Is this Stenotrophomonas? Is this Pseudomonas aeruginosa? We actually know what type of organism that is. And then it will tell us, are the antibiotics susceptible? This is susceptible to cefepime, to ceftriaxone, to piperacillin, tazobactam, and so on. So very important questions. And then we kind of circle back around. So the patient is getting better. When can I stop? Here's the mistake that we've made, and we've made this mistake for a long time. And that is, we said, I'm going to treat people for a longer period of time, and it'll kill all the bacteria, and then it won't come back. Well, that was really dumb on our part, because really, you never kill all the bacteria. It's impossible. You always have some bacteria in this mix of bacteria that have some genetic modification that will be resistant to any of the therapies that you do. So the longer you treat an organism, the greater the opportunity is for it to mutate. And so what you want to do is treat just long enough that you get to the point then that you can let your body finish what you started. You don't have to try to kill all the bacteria because you'll never be able to kill all the bacteria. So if you treat somebody for, say, 5 days for pneumonia, literally probably for 35% of your patients, that's the right duration. For some, it's going to be too long. For some, it's going to be too short. The key is, based on procalcitonin, is you can do serial measurements with procalcitonin and know when that bacterial burden is low enough to let your body actually finish. So you can answer that question, when can I stop antibiotics, simply by looking at these tests, and it will tell you when it's far enough down as far as severity of infection that you can actually stop. And then there's that other piece. The patient's not improving, they're getting worse. Should I change antibiotics? And you can actually look at the PCT to see if it's bacterial. Remember, a lot of these patients have co-infection, particularly right now during the influenza and the COVID season. There is a percentage of these patients that will have the flu virus, and they'll actually have bacteria, and they coexist. And so if you started antibiotics and the PCT is dropping, that tells you your antibiotics are working, but that patient could still be getting more sick. It literally means that they're getting more sick because basically it's from the virus, not from the bacteria. So important information for us to know. The role of viral infections. We probably don't appreciate this like we should. We've always assumed that really sick always equals bacterial infection. That's just not simply the case. 30% of the patients who are on the ICU on mechanical ventilation, who are on the ventilator, actually have viral infections, not bacterial. What's interesting is that viral infections enhance bacterial infections, and bacterial infections actually cause viruses to mutate. They can make them invisible to our immune system, and they actually can make them more virulent. Okay, so it's to understand that what was once always a bacterial infection is not necessarily the same now. So in pneumonia, community-acquired pneumonia, in the past, all of the pneumonias we had were from a bacterial source. This was from a Medscape infectious disease article, and what it indicated was this. You'll notice this says, pinpointing the source of infection in community-acquired pneumonia can be a daunting task that more often than not results in failure. Although Streptococcus pneumoniae, the most common pathogen that has always been Streptococcus pneumoniae, are the most frequently isolated bacterial pathogens, they're no longer the most common cause. In fact, 60% of the patients with CAP, we don't even grow anything. And when we do, the pathogen is usually a virus. It's usually a rhinovirus, influenza virus, or human metapneumovirus. And this is due in use of the vaccines. So once again, just because you're sick doesn't mean it's a virus, okay? And we need to know that, because if not, we're going to be treating people that we shouldn't. So putting all this together, I presented this information to the FDA in the product claim back in 2016. It was published in the paper Open Form Infectious Disease, which is the Infectious Disease Society of America journal. And in our study, we had 2,152 patients, and we applied these concepts. Our control group was 985 patients. Our study group was 1,167 patients. And what we were trying to see is could we reduce the antimicrobial use. We're looking at days of therapy, which is the most accurate measurement of antibiotics that we have. And we're actually able to reduce antibiotic use in our facility, ICU, non-ICU, across the board, anybody who is admitted, by 47%. That's huge. The secondary things that we were able to do is we were looking at hospital all-cause mortality, which was reduced 62%, mortality from infection, which we reduced 59%. And so when people as they go, that's a huge reduction in mortality. It is, but think in terms of this. So the mortality rate in US hospitals is 2 in 100, 2%. So if you simply go from 2 in 100 to 1 in 100, you have reduced mortality by 50%. So it's certainly doable. We looked at things for markers of performance improvement. 30-day all-cause readmission, we reduced 50%, and 30-day readmission from infection, we reduced 49%. Again, very nice, because we actually used fewer antibiotics but had better outcomes. And so then we looked at hospital-acquired C. difficile infections, and what I like to point out is that reduced C. difficile infections by 64%. Which is really interesting is in every study I've ever seen, and I've looked at many hundreds, is that the reduction in C. difficile is always greater than the percent reduction in antibiotics. I've never seen an exception to that. This is a huge opportunity for us to reduce C. difficile infections, and then of course adverse events from C. difficile, from antimicrobials and all those things by 50%. So huge opportunity for us. And this is a very large sample size. This was, 2,152 patients. And so very interesting. So kind of in summary, our laboratory testing has progressed significantly. It can help us identify viral bacterial pathogens much sooner than we ever could, often direct from specimen, and it shrinks that time to result. We now have a biomarker that it has a 94% specificity for bacteria, which is huge, because historically we've never had that. So we think in terms of how does these two work together. One, it helps us identify, is this a bacterial infection versus a viral infection? It can tell us about the severity of infection. It can help us evaluate our antibiotic effectiveness. It can help us a bit with the ability to stop antibiotics sooner. It can help us determine whether what you grow is actually colonization versus infection. And then additionally, what is the pathogen, which antibiotics work, which allows us to narrow and define our antibiotic therapy. We don't want to use a cannon when I can use, a BB gun. I want to use the most narrow therapy I can because they have fewer side effects and they're much less likely to cause Clostridium difficile infections. And then it can actually, which is very nice, it can help us define resistance mechanisms. I actually have the ability now to look at these phenotypes on these organisms and know exactly what resistance mechanisms are placed in here, which can be very useful. The bottom line is fewer antibiotics always reduce the development of C. difficile infections and its consequences, but fewer antibiotics can actually reduce C. difficile, but actually improve your outcomes, which is a huge opportunity for us. So I would open up to questions. This is my personal email address, mrbroyles@suddenlink.net. If you'd like a copy of this presentation, if you have any questions that aren't answered, if something comes up later on, please email me and I'll open it up to questions, please.
Mike, do you see Gerard's question in the chat?
Oh, let me see, let me change here. Okay. Chat. Okay, can you speak to the factors that may impact uptake and utilization of this test, particularly cost and awareness? Absolutely can. Great question. So the test is very simple to do. This actually comes from a blood test. This comes what we call a green top tube, most usually. The cost of the test is around $20 or less. So it's a very cost-effective test. So this test has actually been available in the US for more than 10 years. We've used it for 10 years. It's been used for more than 20 years in the European nations. And there's over 4,000 publications to this test. It's just in the US, we're very slow to adopt It is said that it takes 15 to 17 years to make huge changes in our prescribing processes and adopt new technologies. And obviously that's what we're seeing here. But the factors it's really getting people to believe. Most prescribers are pretty skeptical about a lot of things. We're told when it comes to drug information and things like that to always be, somewhat cynical in a way, somewhat skeptical. But there's a lot of information here. What's really interesting when it comes to antibiotics, it's hard for them to accept procalcitonin and these other tests. They'll jump on board with a test for a cardiac marker, like a troponin for MI or like a BNP for heart failure. But for some reason, when it comes to infection, it's a very difficult thing for them to grasp because it's a very gray test. It's not black and white. It's one that just takes a while. It takes a lot of education. And then typically they look at things like what is something that is, easy to do, black and white, so to speak.
Dr. Broyles?
Yes, ma'am.
Can you talk about C. diff colonization?
Mm-hmm. So C. diff colonization is an interesting thing. So whenever this is a very fascinating concept, actually. So we always have C. diff in our body. I mean, we're not born without it. Even infants will have Clostridium difficile in the body. But what happens is whenever we develop a Clostridium difficile infection, is we develop spores. Now, the spores from Clostridium difficile are incredibly hardy. It's almost impossible to kill them, particularly within the body. And so what happens is when you have a Clostridium difficile infection and you get that infection and you treat that, so once that infection basically resolved itself, you still don't have the diarrhea, those profuse watery stools, the temp goes down and all of those things, the spores remain. And so basically those spores can then reinfect at any point later in life. So once you have a C. difficile infection, you essentially have something that can come back and haunt you for the rest of your life. And these spores, like everything else, are opportunistic. They may be dormant for weeks, they may be dormant for days, they may be dormant for months, but they do come back. And basically 1 in 5 patients, these infections come back. The problem is that when they come back, they usually come back more severe than the previous time. So you have the one admission, the one time that it comes back again and again. And as they progress, they develop resistance quickly. So used to, we would use a drug called metronidazole. Now we use vancomycin. And so then if vancomycin doesn't work that great, then we'll do a combination metronidazole and vancomycin. Now there's one called difficile, which is a different type of thing. And so each case, every time it comes back, it's progressive. The problem is that this can actually cause the bowel to actually perforate where the bacteria leaks out and you get sepsis. It's a very dynamic process, very complicated, but it's one of the things, if you can avoid that infection at all costs from the very first time, you're far better off. And then there's always that cause for concern once you do develop it, that it will come back in the future. Does that answer your question?
I just wanted to know, what do you recommend? Would you treat a quote unquote colonized patient for recurrent C. diff?
So you would only treat that patient if they develop symptoms. They had a profuse watery diarrhea. The testing that you do once they test positive, so we use a molecular test where they test positive. So a molecular test was so sensitive, once you test positive for C. diff, you'll always test positive from then on. So then what you have to do is now you actually have to use a second test where you're looking at the C. diff toxin. So there's a toxin A and B. And so in this, you're actually using a second test to see if they produce toxins. So the question would be, if they're symptomatic and they produce toxin, then you're going to treat them in recurrent. You can't really do anything about colonization other than to avoid antibiotics. Probably some evidence that maybe things like probiotics and those things are helpful, but you basically have to have those criteria met before you're going to treat them again.
Thank you.
Mm-hmm. This is this covered by insurance companies? My insurance company refused to pay for the GI panel. So the question is yes. So it's paid for by all the insurances that we found, both in the inpatient and outpatient setting so far, including Medicare and Medicaid. And then that last question that I see from Lauren is, once you have spores, once you have the infection that's gone, will you always have spores? The answer is yes, at least until we have something that will change that. At this point in time, we'll say that it's a lifetime occurrence until we find something different. Okay, well, thank you, everyone. Thank you very much for your time. Appreciate it.
Thank you so much.